Welcome to the workshop, Protecting Your Health After CAR T-Cell Therapy. My name is Becky Dame, and I will be your moderator for today's workshop. It is my pleasure to introduce today's speaker, Linda Ramsdell. Linda Ramsdell is the Assistant Director of the Immune Effector Cell Therapy Program at Dana-Farber Cancer Institute. That's where she provides patient education and emotional support to patients and families, fostering a holistic care environment. She has been involved in research and presentations at medical conferences on outpatient CAR T-cell programs and the late effects of CAR T-cell therapy and the latest advances in CAR T-cell therapy. Please join me in welcoming Mrs. Ramsdell.
Thank you. I'm very excited to talk to you all today about protecting your health after CAR T-cell therapy. To look at a few of the objectives I hope to cover today, we're expecting to discuss quality of life after CAR T-cell therapy, potential late and long-term effects after CAR T therapy, both psychological and physical, incidence and risk factors for late and long-term side effects after CAR T, self-monitoring for late and long-term side effects, and to who and when to report these symptoms after CAR T-cell therapy, and then lifestyle changes that can prevent and or manage long-term effects of CAR T-cell therapy. So when we think about quality of life after CAR T-cell therapy, generally we think that you're going to have a really good quality of life. Most patients feel the side effects or the symptoms of CAR T-cell therapy after the lymphodepleting chemotherapy and up through the first 30 days after your CARs are infused. Then those symptoms tend to subside. So when I have a patient in front of me and, maybe they're 15 days out, they may still not be feeling great, but they're feeling better than usually that immediate post-CAR period. What might that look like? So a lot of patients, actually most of my patients will tell me that they have a lot of fatigue, decreased stamina. Some patients do have pain, and then other patients also report that they have sleep disturbances. Sometimes patients can get in this tricky cycle of napping during the day and not sleeping at night. And then when we think about cognitive functioning, we think about your attention and your memory and what may be affected there. And then how are you going to transition back if you're going back to work, transitioning back to work after when you're having some of those symptoms? We think about your emotional health. What is your anxiety, your depression level? Do you have any fear of relapse? And your social functioning. So when you're getting back out after your CAR T-cell therapy, what do those relationships and your social life look like? The intimacy and thinking about caregiver burden. We also, when we think about CAR T, we also have to think about financial toxicity, because these therapies are very expensive, and sometimes in order to access the care can be very expensive as well. And then long-term supportive care. So typical of quality of life over time. So in the early period, those first weeks to first 3 months, your quality of life may dip. And that's due to kind of those acute or those the effects after CAR T that just pop up immediately. When we talk about acute, it's in that immediate period. And thinking about the effects after you're hospitalized. So some of that deconditioning or feeling really easily fatigued after your hospitalization. After 6 months, we expect that that's going to improve, or it's going to improve pretty drastically. While some patients may have persistent fatigue, as well as persistent cognition symptoms and infection burden, generally this improves with time. So what are those risk factors when we're thinking about who's going to have a better or worse quality of life? So we're looking at the patient's ability to care for themselves, perform their daily activities prior to CAR. Are you able to do these? Is it already tough prior to CAR? That's going to help kind of determine who may have a better or worse quality of life. If you have other comorbidities or other health issues before CAR, that's going to impact your quality of life after. How many prior lines of therapy you've received can also impact your quality of life, because we're looking at how sick are you coming in? Did you get a ton of chemo before? Are you already feeling pretty deconditioned? All of that is going to potentially affect your quality of life after CAR. How well CAR T cells worked is going to affect your quality of life after CAR. If you have ongoing low blood counts or infections, that's going to affect how you're feeling. Persistent neurologic symptoms, and then all of that psychological or psychosocial support is going to affect how you're feeling after CAR. So when we talk about CAR, it's actually hard not to talk about the early toxicities when we're talking about long-term toxicities. So when we talk about early toxicities after CAR, we're really talking about within that first month post. So these are generally due to the chemotherapy before you get your CAR T cell infusion. So there's lymphodepleting chemo that you'll get before your infusion, and you can get side effects of those. While we're not necessarily giving the chemotherapy to treat your disease itself, we're making your body this favorable environment for those CARs to go into, but those chemotherapies still have side effects. You think about cytokine release syndrome, ICANS or immune effector cell-associated neurologic symptom. There is another, it's called ICANS, so immune effector cell-associated lymphohistiocytosis-like syndrome. It's a mouthful to say, but we call it ICANS. So it is almost like a very, very, very robust CRS, if you will. It's uncommon, but it is serious, and it's very, very treatable with prompt recognition. We also think about infections in that first CAR period, because we are giving you that lymphodepleting chemotherapy. We are going to potentially make you cytopenic, so you're going to be at risk for infection. And we usually give preventative antibiotics for that. So when we think about cytokine release syndrome, so one of those two major side effects that we talk about with CAR Ts, not unique to CAR, but very common after CAR. So we think about the proliferation of CAR T cells. It's increasing the number of inflammatory cytokines in your body. So the CARs they're attacking your cancer. There's the spillage of all these cytokines into your body. You're getting all this inflammation, which is the point of doing this, is we're causing all of this inflammation in your body so that it's attacking your cancer. It is very, very common to have CRS. So about 40 to 90% of patients will get CRS. Certain products are associated with higher rates of CRS. So we may see with one specific product a higher rate of CRS, but maybe it's not as high of a grade. And we'll get to that in just a little bit. Most cases are generally mild to moderate. CRS is very, very, very treatable. We have really great things to treat CRS now too. The key to CRS is you have had to have your cell infusion already. We cannot have CRS, which is a side effect of the CARs activating, until those cells are already infused. And then the duration of CRS is really variable. So when we say that it's product dependent, each individual product has a known timeline in which CRS typically begins, and we'll look at that in a little bit. So when we think about CRS, the typical symptoms are fever, and it can be fever only, and that would be maybe like a grade 1 CRS. You can have all of these other symptoms with CRS as well. So malaise, headache, rigors, or those shaking chills, nausea. It can just kind of stay with those flu-like symptoms where you're feeling, not so great because you have that fever, or it can progress to more significant symptoms, something like a low blood pressure, low oxygen, electrolyte imbalances. And that's probably where we're going to starting to think about intervening with some medicines for you. So during CRS, we see an elevation in your serum or your blood inflammatory markers. So we look at a couple of different markers. One is called a CRP. Another is ferritin, a procalcitonin, or an IL-6. Some institutions may not do an IL-6 and they're only doing a CRP, but basically these are showing different inflammation levels in your body. And it'll clue us in if we're starting to see these numbers go up into spike as to when CRS either is starting to happen or has already started. Sometimes patients do need ICU level of care, but it's far less common now than it was when CAR Ts first started, because we're more comfortable with intervening sooner than what we were before with tocilizumab and or steroids. So when I was just saying that we know certain products act a certain way, so when we're thinking about the CRS incidence, all of these different products have an average amount of any grade CRS, which could be grade 1, 2, 3, 4. And if you're a grade 1, you're a fever only. If you're a grade 4, then that's when you're probably in the ICU. You're really feeling terribly and you need multiple medications to help support you through. And then if you can see, so that kind of like purpley blue number is any grade, and then that lighter blue number is if you were to have severe. So starting to when you're needing to go into the ICU, have that type of level of CRS. As you can see off to the left in that blue, for example, for Axicel, a lot of patients will get CRS, but not a ton of patients are getting that high grade. And the same thing for all of those. So having the high grade CRS is far less common, but having CRS is actually pretty common with CAR. And these are all of the different commercially available CAR Ts that may be offered to you. And they all have different indications, but your provider will find the one that is the best fit for you. So another side effect that we typically talk about is something called neurotoxicity or ICANS. So this occurs when the cytokines are crossing the blood-brain barrier, or the CARs are crossing the blood-brain barrier and wreaking a little havoc on your neurologic system. It can affect up to 20 to 60% of patients. It typically occurs after the onset of CRS. It can occur independently of CRS as well. So even if you've never had a fever, sometimes you can get the neurologic effects. It can last from days to weeks. It really just depends on what's going on inside of your individual body. And then most cases resolve with treatment, which is usually steroids. So the symptoms can be either mild to severe. Sometimes it's just a little bit of forgetfulness. We might notice that a patient's having a little bit more difficulty navigating on their phone, something like that. Maybe they're having this little slip where they were trying to say one word and they said something else instead. It can be progressed to things that are much more serious, like seizures and swelling as well. There is a standardized question tool that assesses memory and cognition that we use when we're thinking about how we're grading ICANS. And then the treatment is steroids. Most cases are reversible, and again, some cases are going to need ICU level of care. So when we think about ICANS, the same as CRS, where every different product is going to have some level that you may see of this, but they're all a little bit different. So again, looking at our kind of like bluish purplish box on the left, that is going to be any grade. So it can even include the lower grades, grade 1 and grade 2. And then that light blue on the right is going to be the more severe, so the grade 3 or grade 4. Grade 4 is when you might be probably in the ICU at that point. As you'll notice, the numbers are a little bit decreased from what we would have seen with CRS for the very same products. But it's something that we're going to watch and we're going to intervene on and be very careful with you about. So now when we think about toxicities between day 29 and to day 100, we think about infection risk. Infections are actually pretty common after CAR T. Mostly viral infections are kind of what's complicating this post period. You can have a delayed neurologic problems, which are very, very, very uncommon. They could include headaches, tremor, and cognition changes. And then some patients have developed a Parkinson-like syndrome as well. When we think about the low blood counts, so very, very common after CAR, sometimes people may need transfusions or growth factors. Very rarely would we need to do something beyond that. It's actually very common to get, we call it hypogammaglobulinemia. So it's an abnormally low level of antibodies in the blood. It impairs your body to fight infection. It results as a destruction of the normal B cells because that's what the CARs are actually targeting. So we think of it almost as collateral damage. So if you're getting, any product for, say, lymphoma, we're going after those B cells, and those B cells are what the healthy B cells and the malignant B cells are what are being targeted. unfortunately. It does affect the majority of patients, and it can persist from month to year, but there are things that we can do to help with that as well. So again, persistent low blood counts are very, very common. It's, a mix sometimes of prior lines of therapy and how much chemo your marrow has seen before, in addition to the lymphodepleting chemotherapy and sometimes just the suppression from the CARs itself. You may have a weakened immune system and be more at risk from having these low blood counts. Again, very common to have that B cell aplasia because our CARs are actually targeting those B cells, whether or not they're malignant or cancer cells or the healthy B cells. That results in low antibody levels, which will help your body recognize things as foreign, or I should say those kind of viral infections and things as foreign. And it can persist for years. When you think about neurological and cognitive effects, again, they can be very common. You can have some difficulties with your memory, attention, or even information processing speed. There are also cardiovascular or heart effects that we can see after CAR. It's primarily in those who have had a really severe form of cytokine release syndrome. You can also get secondary cancers. They are extremely rare, but as with most other treatments, there's always a little bit of a risk and a side effect there. You can see MDS or potentially AML or T-cell lymphomas as well. And then there are psychological or psychosocial effects. Those again, they can be relatively common. They can present like anxiety, depression, be precipitated by financial strain or even relationship changes when we think about some of the burden on our caregivers. So when we're thinking about the long-term monitoring after day 100, so usually it's about every 3 months. Every institution may have a little bit different of a timeline in which they want to see you, but generally we're seeing our patients every 3 months after they receive CARs. Then typically after you hit that 1-year mark, it's annually. And the things that we look for are, do you have infections? What's your immune status? Do you have that hypogammaglobulinemia or those low immunoglobulins in your body? Those are like memory cell antibodies to help you fight off infections. Do you have CAR T-cell persistence? We're screening you for any new malignancies or secondary cancers, ongoing neurologic complications, cardiovascular complications, if you had one of those really severe CRS syndromes. What's your respiratory status, your GI status, and how's your liver looking? Does it look happy after CAR, or did it get a little inflamed? So we think about these late effects of CAR on the bone marrow. We really think about those low blood counts. So they could be prolonged, where your blood counts after your CAR T-cell therapy never truly recovered really robustly, or it could be recurrent, where you had your blood counts come up and now we're seeing them dip down again. We've talked about B-cell aplasia and hypogammaglobulinemia, and again, that is the low level of B cells, and the B cells make antibodies. When you have the low level of antibodies made from those B cells, that's your hypogammaglobulinemia. You may have had IVIG before, depending on which disease you're being treated for. So it's something else that we can restart after or start newly. And it's an IV infusion that typically it might be monthly. Then you can also have delayed B or T cell recovery. So when we think about the late effects of CAR T cells and we're thinking about infection, we're thinking about late bacterial infections, viral reactivation in select patients, and then these nasty opportunistic infections that we don't want anyone to get. You can give this antimicrobial prophylaxis, or we can give you some sort of, when we say antimicrobial, so like an antifungal or an antiviral after to help prevent and like almost like boost your immune system up a little bit as part of your survivorship care. So what this may look like. So when we're thinking about that timeline after you receive CAR T-cell therapy, when we're in that first 30 days, that's when we're thinking you're going to be at highest risk after your lymphodepletion chemotherapy for things like bacteria in your blood or bacteremia, gastroenteritis or diarrhea or infectious diarrhea, And then pneumonia can be more common in that particular period when your cell counts are really at its lowest. You can have viral reactivation with shingles or chickenpox. And then there, depending on where you are in your treatment, you could get some of those respiratory viruses that are seasonal and those intermittent, depending on where you are in the season in that first 30 days. In that first 30 days, you're also going to be more likely to get candida infections because of your counts being low, as well as a little bit more susceptible to mold infection. Once we get beyond that 1 month period, that's when we're seeing things like the seasonal viruses and something called pneumocystis pneumonia, and then some mold infections as well. Up until usually it's that 6 month period, we're not really looking to take you or peel off any of the prophylaxis and seeing what are the CD4 counts. But some people, it could be a variable timeline. Most institutions keep it on for 6 months. So with that, within the first usually 2 weeks post-CAR, when your blood counts may be at their lowest, that's when we're thinking about using a medication called Levaquin, as long as you're not allergic, to prevent any bacterial infections if your counts were to be very low and you were considered to be neutropenic or have a very low neutrophil count. For the viral infections, usually we keep that on for about 6 months post, and it's usually something like acyclovir or valacyclovir. We don't usually take that off before that 6 month period because we're waiting for some of those cells that we know that we depleted, right? With the lymphodepletion, we're taking away the subset of your lymphocytes. We need that to actually repopulate in your body. So usually we're keeping the either acyclovir or valacyclovir on for at least 6 months before we start checking that CD count or that lymphocyte count to make sure that you have repopulation. You can start revaccinating as early as 6 months. That being said, not every institution revaccinates, so the practice is actually a little varied. Your institute might, well, many others might not. It's just going to depend on where you're being treated. When we look at fungal infections, so that gray bar down towards the bottom, usually within the 30 days is when we're seeing the height of the fungal infections. We may put you on something called fluconazole, depending on, some people do it as prophylaxis. Many institutions have gotten away from that, but it's still pretty common. After that, we're thinking of using, and usually this actually starts with CAR, but we give you the protection against PJP pneumonia or pneumocystis pneumonia. We usually keep that on for that same 6 month period because we want those lymphocytes to come back up. At that 6 month mark, we may check something called a CD4 count, which is showing a subset of your T cells and whether or not they're repopulated. And if it's over a certain number, and most institutions have that magic number at 200, that's when we may peel off those prophylactic antimicrobials. So either the acyclovir or valacyclovir or the Bactrim or the trimethoprim sulfamethoxazole. Usually starting around 30 days is when we're going to start monitoring you for hypogammaglobulinemia. So that could be when we're doing the IVIG replacement for you. So we're thinking about late side effects of CAR T-cell therapy. We're thinking about neurologic and cognitive changes. We're really looking for what are the symptoms. So we're looking for, do you have decreased attention, or are you having memory problems? Are you processing slower than usual? Do you have headaches or sleep disturbances? Less common is neuropathy. Some patients can get some tremors, so some hand tremors, so something like bringing a spoon up to your mouth may be more difficult. We're looking for mood changes too. It's often caused by inflammation. Sometimes, these are the patients who may have had an ICU course, have more steroids, have anemia, or sleep disturbances. When we think about your heart health after CAR, so again, it's unusual or uncommon to have long-term cardiac effects after CAR. If those were to occur, usually it's after severe cytokine release syndrome or a very prolonged ICU stay, and that's from all of the inflammation that was created. Some people do have deconditioning after CAR. So it's very common after someone's hospitalized for a period of time to be more deconditioned. So maybe your heart rate might be a little bit elevated where you weren't before, because you're getting used to getting back and getting active. We see reduced stamina, and then usually that improves with physical activity. There is a small risk of anemia or arrhythmia, rather. Again, it's very uncommon that would happen, and usually it's going to be there was some sort of pre-existing condition. So just giving you an example, if you have atrial fibrillation and you've been in really good control, sometimes when you're in that inflammatory response with CAR and the fluid shifting a little bit, that can trigger you to go back in. And then sometimes we're thinking about the effects of steroid use on your muscles too, and your heart is a big muscle. So again, it'd be a very, very rare effect. The data on that is really still evolving. And then symptom-triggered cardiac evaluation is recommended. So, it's not routine to need cardiology after CAR, but depending on what your course may look like, you may be referred to cardiology after your CAR T-cell therapy. And then again, these are very, very uncommon, but it is very, very, very manageable. When we think about secondary cancers, so they're cancers that are caused from prior treatment. They're rare. A very small percentage of patients may get these. T-cell malignancies are the ones that we think about with CARs for themselves, and again, extremely rare. A few years ago, the FDA issued an alert on this, but it remains very, very uncommon that we would see anything that was T-cell driven. Obviously, any new malignancy is very serious, but usually it's very treatable. Regular monitoring will help with early detection, and just, I'm sure, as you're doing all of the things that you should be doing for yourself and reporting everything to your oncologist. Again, just if you see something, say something to them. What you would say, or what you would report, is if you have any unexplained fatigue, new weight loss, sweats, or new lumps, because that could be a little bit more T-cell driven. And then when we think about the late psychosocial effects, so anxiety or depression, depending on how your course went, or, some people find anxiety post, especially if they had some significant side effects after trauma-related symptoms after IC or hospitalization. There's always going to be, some people just have this terrible fear of relapse, and that's totally understandable. Sexual health concerns, and it's really important that you talk to your oncologist or your nurse practitioner about any sexual health concerns, because that is something that they can refer you to a specialist for. Thinking about relationship strain after CAR, caregiver distress, because, depending on how you received your CARs, some are in the outpatient setting, some are in the inpatient setting, but there is going to be a little bit more caregiver burden in the outpatient setting. And then financial toxicity, because obviously these therapies are extremely expensive, and ongoing medical costs thereafter from this. We think about what are the risk factors for having these late effects after CAR. So patients who have advanced age, patients who have more comorbidities, which are more health problems. So, if you had more problems with, say, like diabetes or heart complications, things like that going into CAR T-cell therapy, that would put you at just a higher risk for having some of these late effects. Baseline frailty or performance status. Performance status is something that we look at of, how challenging or how easy is it for you to do some of the daily tasks. When we think about disease factors, we think about high disease burden. So do you have really big, bulky tumor? Have you had a prior transplant? Are there cytopenias, that kind of baseline of how your marrow is functioning? You might be more at risk for having low counts after. When we think about your treatment itself, the severity of CRS and ICANS, whether or not you needed a hospital stay, and then really the culmination of steroid and tocilizumab exposure. So how often did we have to intervene, and what were your inflammatory markers? Then obviously profound decrease in your B cells are going to make you a higher risk for infection. We think about self-monitoring for side effects. So when we're thinking about infection and blood counts, any sign of infection, I want you to report it to your oncologist. So fever, chills, new cough, shortness of breath, painful urination, new sinus symptoms. If it's making you pause, if it's new, it's better to just give them a quick call, make sure that it's nothing serious. They may want to bring you in for evaluation or testing. We think about symptoms of bleeding or low blood counts. We're thinking, do you have easy bruising? Do you have these tiny little red dots on your skin? It's called petechiae. Do you have prolonged bleeding? If you do a quick cut, on your hand, is it bleeding for a really long time? Do you have bleeding gums? Very severe fatigue or dizziness can also be a sign of low counts and anemia. For neurologic effects and cognitive symptoms, we want you, and it probably wouldn't actually be you, it would be more your caregiver, but thinking about new confusion, always report new confusion, severe headaches, new weakness, seizures. And probably with the seizure, you're not calling your oncologist, you're probably calling 911, but call your oncologist after. Significant memory problems, whether new or ongoing, and then significant changes in the ability to focus or pay attention. When we think about self-monitoring for side effects in the lungs, the heart, or just generally, if you're having chest pain, palpitations, new shortness of breath, fainting, and leg swelling, those are all things to report, whether urgent or emergent. Other things that we want you to report are unintended weight loss, persistent night sweats, new night sweats, new lumps or bone pain, because again, we want to make sure that you're reporting everything that we would maybe want to work up for a secondary infection or new infection. So when we think about when do you need emergency care, so fever, always follow your CAR-T team's instructions. Not everyone may manage a fever emergently, but rather maybe urgently. So always call your oncology team to ask them how they'd like to proceed with the fever. Chest pain, shortness of breath, new neurologic deficits, seizure, and uncontrolled bleeding are always an emergency. So again, some of these may warrant you calling 911. Other may warrant a same-day visit with your oncologist, but definitely give them a call. Or if they've told you for any of these symptoms, call 911, call 911. When to seek care within kind of that 24 to 72 hour period, which for me is more urgent care, with a worsening cough, moderate shortness of breath, persistent vomiting or diarrhea, thinking about what's their risk for dehydration there. Any new significant bruising, worsening fatigue, or shingles-like rash, definitely give a call. Definitely give a call because they may want to see you. When we think about seeking routine follow-up, so mild but persistent fatigue, sleep issues, any mood changes, sexual health concerns, I don't think that this is actually talked about enough in any survivorship care. There are specialists that can help you with this, and we as medical professionals don't talk about it enough. So I just really want to impart any sexual health concerns. I want you to talk about it. There's definitely things that we can do and things that we can try. And then return to work and school challenges. Obviously, it's going to be a transition period after. So after CAR T-cell therapy, who should you call? So always call your CAR T center or your oncologist team first, especially during the first year. Obviously, if it's a true emergency, we want you to call 911 and then you can call after. But in general, for those non-emergent symptoms, call your CAR T-cell center because it could be a side effect post-CAR. If you're primary care clinician who is coordinating with the CAR T team, you can also let them know as well. So who to contact when a referral is appropriate. So if you have persistent cognitive neurologic symptoms, you may need to see a neurologist or a cognitive rehab specialist. For persistent heart problems, you may need to see a cardiologist or a pulmonologist. For depression, anxiety, or PTSD, it may be a mental health provider, a social worker, a psychologist. And then for deconditioning, so when you have that muscle weakness, you may see a physical therapist or occupational therapist post. For lifestyle changes to manage the risk of infection, I can't say enough: hand washing, hand washing, hand washing, hand washing. It is the easiest way that you can reduce your risk for infection. Masking in high-risk settings when you're immunocompromised, which you're not going to be as severely immunocompromised after CAR T-cell therapy than you are for transplant. So you may not need to do this as much or as often, but definitely ask your provider about it if it's something that you should be doing. Thinking about food safety and not eating things that may make you sick. Travel precautions, so definitely talk to your provider before you go off and you travel, and have just a collaborative discussion with them about what that may look like for you, or any preventative things that you may do before travel. Dental care and skin care to reduce, the different portals of entry. So really, really good mouth care and really good skin care. And then vaccination plan adherence once cleared by the treating team. So again, every institution revaccinates differently. At my institution, we actually don't revaccinate. At other institutions, they do an entire revaccination series like you would after BMT. And then some institutions land a little bit in the middle where they'll do some, but they don't do all. So it's just going to depend on the practice of your institute. And then when we think about improving functioning after CAR T-cell therapy, so remaining physically active in rehab or getting reactive, gradual return to this aerobic and resistance activity to improve your fatigue, your stamina, your strength, and your mental health. Addressing deconditioning after the hospital ICU, so getting in with physical therapy or occupational therapy earlier when indicated, and then cognitive rehab strategies as well. And then improving sleep, so establishing a sleep routine, so train your brain, so using the bed only for sleep and for sex, and that's it. Limiting alcohol, because alcohol will mess with your sleep, as well as caffeine. And then thinking about decreasing screen time or light strategies before you go to bed. So not on your phone, not watching TV, things like that. Maybe just reading like an actual paper book, which is less common now. For mental health, screening for anxiety, depression, or PTSD, potentially CBT therapy, thinking about support groups. Exercising can also help with your mental health, and then caregiver support as well. So for key takeaways, most people feel better over time, and this is really, really well tolerated. It can take weeks to months to get your strength back and get you back to your full functioning. But in general, people feel well after CAR, and your quality of life will improve. Some symptoms will linger, but again, this is the time to talk to your oncologist about that and see if there's any intervention that they can do to help you feel better too. Common side effects that can show up later are low blood counts, weak immune systems that can lead to infections, and then these ongoing kind of like brain symptoms like trouble with memory or focus. And then risk factors. If you have a high disease burden or as the slide said, like a lot of cancer treatments before, or you have big bulky disease, low blood counts before CAR T cells, or really significant side effects during your CAR T cell therapy, like fevers or a lot of inflammation or confusion. And then when to call your CAR T cell therapy team. You always want to call them after CAR if you have a fever, any unusual bleeding or bruising, new confusion, trouble breathing, and then there's a bunch of healthy habits that can help you feel better. So gentle exercise and introducing yourself into more exercise post-CAR gradually, getting good sleep, eating healthy food for you, and then supporting for stress. And now we'll move on to questions. Here you are.
Hello, this is Lynn. Can you hear me?
I can hear you.
Okay. Thank you, Ms. Ramsdell, for this very informative presentation. And I would like to encourage people to continue to put some questions that you may have in the chat on the lower portion of your screen. And we do have one question that I'm going to start with, and that is, I am a Carvykti transplant patient from November 2025. I am still experiencing side effects, Bell's palsy, muscle weakness, and GI colitis from this transplant. How much longer would you predict these will continue? What can I do to resolve these?
That's a great question, and I'm so sorry that you're feeling so poorly after. There are some neurologic side effects just for everybody who's on the call. So Bell's palsy can happen after CAR, and it's something that we do see sometimes with the Carvykti product or Solticel, as well as GI colitis. I would say that the way in which patients recover from both of those things is actually a little bit variable, and it's going to depend on your body and how your body reacts to the treatments. It does sound like you've been having these symptoms for quite some time, so I would actually recommend, if you haven't seen a specialist, a neurologist, or a gastroenterologist, I think that you should probably get plugged in. There's a lot of different ways in which we can treat, particularly with the GI colitis, and for ongoing Bell's palsy. So I would recommend seeing specialists for those.
Thank you. Can CAR T-cell treatment have an impact on your dental health?
It does not usually. So I know that with bone marrow transplants, you have to do really robust mouth care, and you have to be really careful about your dentition, but we don't have really that same side effect. After CAR T-cell therapy, we do recommend good oral hygiene because we think about more portal for infection. We don't want you to get any sort of mouth infection while your counts are low, but very different than transplant.
All right, thank you. How can we find CBT groups or therapists?
So a lot of times your insurance will be able to help determine who would be within your plan for either a CBT therapist or just a general therapist. And if not, then I would recommend actually reaching out to the CAR T Center because they may be able to have social work, either see you as a therapist or know someone who specializes in oncology.
Good advice. I would like to add that BMT Infinite does have a directory of providers. So if you do need to go outside of your center, you go online and you can find a directory of mental health providers, and they are vetted that they do know about CAR T-cell therapy and the whole process. So you can search by the state you're in, see if there is a provider, and get connected to somebody who knows, and you could be starting and being treated by that person who knows about CAR T-cell therapy and what the long-term effects might be, and is very willing and able to treat you and knowledgeable. We also have a CAR T-cell therapy online support group, and that's also on our website, bmtinfinite.org. And it's under our events tab. So you may find peer support there in our online groups. And I recommend, or I suggest, that you take a look at that and get yourself on a waiting list if you have interest in it. So, next question. Would you recommend probiotics for GI colitis post-CAR T treatment?
That's a great question, and it's actually probably a little bit more controversial than what you may think. I would say the best answer is going to be listen to our oncologist and what they say. But we have seen in some settings with immunocompromised patients that probiotics can actually increase the risk of infection. Again, I don't know that that would be the specific case for you. I think it's a really interesting question, actually, given that there's a little bit of divide there. I think that if you're thinking about the GI colitis, you may be more likely to have that leaky gut, and it could be a little bit more of an infection risk, but definitely have that discussion with your oncologist because they'll be able to direct you the best. They're going to know what therapy you're on and what your individual risks are.
Very good. That makes total sense. You mentioned in your presentation about the lack of sexual health discussions with providers. So this person is asking, are there projects or initiatives to increase this awareness? Are there better resources for us?
We have the beginnings of them, yes. So there are now survivorship clinics that will automatically plug you in. I feel and I hope that more providers within the field are starting to talk about these post effects with their patients, but I think we can still do a much better job than what we're doing. It's really with the survivorship clinics that we're seeing this increase in having these discussions and really getting all patients the help that they need to return back to their true baseline and, engage in some of that activity that would really make them feel, a little bit more like they were before CAR T or before transplant, which is really important.
Okay. That's good to know. And I would like to also mention to everybody who's interested that in this symposium on Wednesday at 7 p.m. Eastern Time, we are going to have a presentation on sexual health after CAR T and transplant. So join us then. Another question that just came in. I am still getting Granix shots after almost 1 year of post-CAR T. My platelets are borderline and so are my neutrophils. Is it uncommon for this amount of time?
I would say that it is possible that that is uncommon. I think it would depend on why your provider thinks you need those shots and are having those low platelets at this time. Sometimes, depending on where your bone marrow function was before, it may be a little bit more back where your baseline is, and thinking about the other treatments are really what the cause is. So that's a great question. I think that it is definitely prolonged, but it may or may not be abnormal.
Okay. The side effects or the long-term effects and the items that you're watching, the providers are watching out for long-term. The question is, if you have a CAR T for multiple myeloma, is that any different than if you have a different disease diagnosis like lymphoma?
Yeah, so what we see for lymphoma CARs and for multiple myeloma CARs post in like more of that acute toxicity phase are actually very different. So with lymphoma, we're actually going to see potentially more robust with some of the products, more robust side effects with cytokine release syndrome and with neurologic toxicity than we will with some of the multiple myeloma products. The timelines are actually very interesting too, where one of the multiple myeloma products, all of the immediate post-CAR toxicity happens on day 1 and day 2. And all on the other end of things, all with the other product that we give, everything happens on day like 7 and day 8. We typically see higher grade CRS with the lymphoma products, although there is one where we see usually up until grade 2, which is fever and a little bit of low blood pressure, low oxygen, and it just kind of stays right there. So it's really, I know that I said it earlier in the presentation, really about knowing which product you're getting, to know which side effects to expect and when, and how much of those side effects to expect. But yeah, all of the products are just so different. That we give, and some patients feel kind of crappy earlier on and like not so great, they'll feel good for a week and then they'll start to feel those side effects.
Okay. Thank you. This person says, it's a little specific, but let's see if maybe you can answer it in a general term. I got basal cell carcinoma 8 months after my second CAR T and 3 years after my first CAR T. Is it likely a secondary cancer, or is it a result of ordinary aging?
So I would say it is likely due to aging. When we're talking about secondary malignancies after CAR, I was more referencing like T-cell lymphomas or like MDS or AML. I think it's a very interesting question, and I think it would depend on what they thought the origin really was, but it's actually pretty common with advancing age.
Okay. Who should they talk to? Their transplant?
I would talk
to different.
Yeah, definitely talk to your CAR T oncologist if you can. Where it's not really T-cell driven, I would suspect they would not think that it is a secondary, but again, it's going to depend on what your oncologist says.
Okay.
I'm only speculating.
Thank you for that. And also, this person is wondering on the issue of caregivers.
Mm-hmm.
How long should a caregiver hang around, so to speak? How long is it advantageous to have a caregiver after CAR T-cell therapy?
That's a great question. And I think it's not as straight of an answer as what you may think it is. So your CAR T institution is going to, for lack of a better term, mandate you to have a caregiver for a period of time. At my institute, it is a minimum of 14 days that you have to have a caregiver. We actually extend that out depending on if you have the neurologic side effects. We usually do it about a week after. I think that question is going to be also, it's a minimum of 14 days, depending on the product. But how are you feeling and how long do you feel like you need them? Because every patient's going to recover differently. So if you're having really significant fatigue after, you're going to need that caregiver for longer. You know, we have some patients who really do feel a little bit knocked down after CAR, and we have other patients who are outpatient, and they're walking 1-2 miles to get to us every single day. So it's really going to depend on how you're feeling post-CAR.
Good advice. Thank you. So we are done with our Q&A now, and I would like to wrap up by saying, on behalf of BMT Infinite and our partners, I'd like to thank Ms. Ramsdell for a really very helpful presentation. Thank you, audience. You had excellent questions. And please stay online to complete a brief survey. Your feedback is important for us as we go forward next year and design new programs. Goodbye. Have a great day.